Assalamu alaikum. I welcome all of you on board. Actually, because of request by some of the people in my circle, does not understand our native language. So from now onwards, I will be trying to communicate in our this discussions majority of the things in English. If someone doesn't feel comfortable, he or she can still ask anything, and then I will try to make it understandable to everyone. Okay. So just to give an overview of what we discussed yesterday, we just try to have discussion on neuromuscular junction. Okay, so we just discussed that how activity occur at the level of neuromuscular junction, how the impulse is coming, and how acetylcholine is released, and how it acts on the postsynaptic acetylcholine receptors, and then this nerve action is converted into the muscle contraction by the this activity which occur in the muscle fiber. Okay, so today we will be translating and also we discuss about the neuromuscular monitoring. So today we will be starting from Myesthenia gravis. So like any of you, if you can just tell what is Myesthenia gravis, who would like to tell? Just raise the hand. Whosoever wants to take the lead. Azhar, would you like to say something?
Sir, yes, of course. Thank you so much for your time and all. Myasthenia gravis is an autoimmune disease in which there is antibodies are created or made against the postsynaptic receptors, and clinically there is a decrease in muscle power of the affected person, sir.
Okay, you have elaborated in a very nice way. So how clinically this disease present? Like what are the area of interest? Like you told that there is problem in the postsynaptic acetylcholine receptors. They are being destroyed probably through some autoimmune mechanism, but sometimes these antibodies are not being identified. Okay, but still they theoretically say that there is autoimmune destruction of the postsynaptic acetylcholine receptors. Okay, so now the next question is that how myasthenia gravis clinically present? Like what are the like if you are as anesthetist, what will be your area of interest? What you will be thinking? What you will be
Sir, it presents with the muscle weakness, and specifically with the exertion or muscle activity. Gradually, there is more weakness with the activity. One, and as far as I'm concerned, there will be I'll be concerned about the airway in the advanced form of the disease. There will be a weakness of the bulbar muscles, and there will be a weakness of the respiratory muscles as well. And it really ascends in the ascending order. It usually starts from the peripheral muscles.
No, this is you are mixing it up with GB syndrome. This occurs in GB syndrome. This occurs in GB syndrome. And this is not the presentation of myasthenia gravis actually. Okay, so you told in right way bulbar function. So what will be the effect of weakness of bulbar muscles? Like bulbar muscles mean pharyngeal muscles which are controlling the mechanism of how it converts in from a food pipe to a windpipe every now and then. Okay, so this mechanism is disturbed. So because of bulbar dysfunction, bulbar muscle weakness, there will be chances of aspiration. Okay, and the thing which you were telling about other muscle weakness, the main effect will be on the muscles which are required for the respiratory system, and their weakness will result in decrease in mechanics of the lungs. So that will be evident in the form of decreased ventilatory capacity. Okay, so the lung volume and capacity will be decreased. Predominantly, what thing we focus for it? Which lung function we monitor to see the extent of this myasthenia gravis in the form of respiratory function? How can you quantify it?
With the help of pulmonary function test?
Pulmonary function test. What specifically? What of which of them? Vital capacity. Okay.
Capacity.
Yes. Vital capacity for the lung mechanics, and the result will be in the form of ABGs, like there will be VQ mismatch or whatever. But in initial stages, you will quantify how severe is myasthenia gravis on the basis of this like vital capacity. Okay. If it is less than certain, and bulbar weakness, you will have history of regurg. Okay. And another way to see the severity of the disease will be to see the how much dose of anticholinesterase patient is taking. Why we which actually anticholinesterase we use, and why? Yes. Anyone, please?
Pyridostigmine.
And why not anything else? Like what?
Because it has a long action.
Long action, and what else? Would you like that drug to cross the blood-brain barrier or no? Yes, Azhar?
No.
No? Why no? Yes, anyone, please? And what about physostigmine? Can physostigmine be used for?
Yes sir, physostigmine sir इसमें यूज नहीं करेंगे क्योंकि वो ब्लड ड्रेन
You know, actually, Dr. Sahito, if you don't mind, please, if you can communicate in English, because we have some international audience. So we.
Sir, because sir, physostigmine cross the blood brain barrier. That's why we need a peripheral effect. Because there are the peripheral antibodies found in this myasthenia gravis. So
yes.
physostigmine.
Actually, so we don't need its effect in the central nervous system. We only need the effect to be in the peripheral system. Okay, so everyone is clear. So that's why pyridostigmine, which is like usually the drugs which are big molecules or are ionized or charged, they are not able to cross the barriers like placental barrier or blood-brain barrier. Okay, so. So now coming back to the more important features which we told about bulbar weakness, the respiratory muscle weakness, and other, which is the selling point of myasthenia gravis, is eye. Okay, but usually it is not too much important for anesthetist. Yes, as in your any exam, they can ask you about the ocular weakness, but actually it's not that much important as compared to bulbar weakness and the respiratory muscle weakness. Okay, so whenever we want to predict the danger of having post-operative morbidity and mortality related to myasthenia gravis, we either say it in the form of duration of the disease, more than 6 years. Okay, the dose of pyridostigmine more than 750 milligram, coexisting respiratory disease. Okay, and is there any if there is any evidence of bulbar weakness. Okay, and some other autoimmune disease which are there, and coexisting respiratory disease is very important. Okay, so in the form in the patients in which these of the factors are there, and upper abdominal surgery. Okay, so you will be thinking that there will be arrangement of the post-operative ICU or HDU. Okay, this is one thing. Yes.
There is another thing. So if there is vital capacity less than 40 ml per kg,
Dr.
functional
Zahiro, I would appreciate
capacity-
one thing. If you can just switch off your speaker, because there is so much echo, I'm not able to listen to you clearly. I will be really thankful to you if you just remove your headphones and try to speak out with directly. Yes, please.
Yes, sir. If it is also an indication.
Yes, now you can speak, please. We can hear you.
Yes, sir. Yes, sir. There is also other indication in addition to that.
Unfortunately, Dr. Saito, we are not able to listen to you.
Less than 40 ml per kg, 2.9 liters.
Yes, I wish I am able to listen to you. You have some problem in the internet. Can you speak again? Yes, unfortunately, there is some problem to you. I would appreciate if you can just write in the chat box. I will speak it out, or if you can fix the problem. So these are the things which you have to see. Okay, and like any other disease, you would like to optimize the patient. Okay, so optimization will be on the basis of the treating the disease pathology or the symptoms related to it. Okay, symptoms related to it, like for example, if you are giving patient is having smoking, you can stop the smoking, so it will improve the post-operative outcome. If there is some coexisting COPD, you have to treat that disease. If, for example, the patient's condition is not stabilized, you can refer the patient to the endocrinologist or physician, whosoever is taking care of neurologist, whosoever is taking care of the patient, to optimize the dose of the anticholinesterase. Okay, then you can advise the patient to have incentive spirometry. Okay, then you can discuss with the surgeon to have, because this patient can present to you in two different forms, either myasthenia gravis patient for thymectomy, this is one category, and myasthenia gravis patient for any other surgery. Okay, so things will be a little bit different in both of them. If it is for thymectomy, the consideration will be according to the surgery. If patient is having any other surgery, the myasthenia gravis will be the main background music around which you have to sing. So your main concern will be myasthenia gravis plus the surgery. Okay, so in either of them, you will have to target the post-operative outcome. For that, you will try to just treat the treatable things, optimize the patient, in whatever way you can. This is actually very nice thing to just revise it. Like maybe the treatments, whatever patient is taking, maybe it will be helping with the plasma exchange. Okay, short-term remission, can be treated. Patient will be taking immunosuppressants. Patient will be taking steroids. Okay, so you can achieve the optimal conditions. Okay, because of this disease pathology, you will have actually in addition to the airway, you will have problems associated with the patients taking steroids. So you have to replace the steroids with the stress dose. This is one thing, and you will be facing the side effects of the immunosuppressant patient might be taking. And another thing is that patient might have some other coexisting autoimmune disease. So you have to consider all these things in your mind. Okay, and because the main thing which you will be facing according to the pharmacology will be the altered response to the neuromuscular blocking agents. We will just discuss those changes very shortly. Okay, so they have written some other like clinical history, EMGs, anticholinesterase antibodies. They can find sometime, and tensilon test. Actually, they can ask you adrephonium test, and this is to differentiate between myasthenic crisis or cholinergic crisis. Okay, so they are giving adrephonium, and if the symptoms are getting better, so patient was in myasthenic crisis, and you have to increase the dose. And if, for example, the symptoms are worsened, you have to decrease the dose of anticholinesterase. So this test it has to be done under the in a scenario where you can face any cardiovascular instability in the form of any vagal responses or airway problems, secretions. Like you have to just do this test under appropriate care. Okay, and what else? So these are the basic things about the pathology of the myasthenia gravis, its treatment. So we are not discussing in detail at the moment about the immunosuppressants, but usually these immunosuppressants, what you have to remember and recall all the time, these have effect on multi-systems. Like these can cause disturbance in cell lines because of their effects on bone marrow. This is one. They can affect on renal system. So it can cause nephrotoxicity. They can cause renal failure. They can have effect on liver. So there can be elevated liver enzymes. Okay. So you have to take in consideration all these things when you are giving, and you have to replace the equipotent doses of steroids in the form of a increased stress dose, which will be required in addition to the dose which patient is taking. Okay. So these are the main points regarding myasthenia gravis. And regarding this altered response to neuromuscular blocking agents, there will be increased sensitivity to which drug? Who will tell?
Non-depolarizing.
Sensitivity. Why? What is the reason for this increased sensitivity?
Actually, sir, may I tell something?
Who told this non-depolarizing? Let that person speak out, and then if you want to add something. Who told this non-depolarizing? Who speak out? Please. Anyways, yes, Azhar, you can tell.
Actually, as we discussed, there's a decreased number of acetylcholine receptors. There is a decreased number of receptors. So as we use the non-depolarizing cells, so that will occupy a small number of muscles. So there will be a difficulty in reversing the effect of those muscle relaxants.
No, actually, my question was that which neuromuscular blocker the patient will be sensitive. Okay, so sensitive to non-depolarizing, but you are not able to explain the reason. Can you try it again, please, Azhar?
There is down regulation of the receptors.
Down regulation of receptors? No, it's not the reason. Actually, non-depolarizing neuromuscular blockers act like competitive antagonists. Okay, so there will be competition. So if there are less number of receptors, so there is less dose is required. So this is very sensitive. Like for example, before there were 100 receptors, and atracurium has to fight for 100 receptors. If the 50% or 80%, whatever receptor occupancy will be achieved, and then there will be clinical effect. Okay, now there is only, for example, 10 receptors are left or 20 receptors are left. So even with the smallest of the dose, that dose is enough to compete with acetylcholines which are there, and they are blocked, and the effect is achieved. Okay, so that's the reason for sensitivity of the neuromuscular blocking agents. And if you talk about dexamethasone, what is the effect, Azhar?
Sir, they will occupy that receptors.
Okay.
And that will be difficult, or as there is a very decreased number of receptors, so dexamethasone will join them, and that will be a complete blockade of the receptors.
No.
And for the reversal, there will be a new growth or regrowth of the receptors.
Sir, the reason now there is resistance to dexamethasone. Okay, dexamethasone, there is resistance in myasthenia gravis. The reason is that there are no receptors. Dexamethasone needs receptors because it is depolarizing. Okay, if you don't have the receptors, there will be resistance to that drug. Okay, so actually you need more dose for the same effect, and the effect is unpredictable. And if you go higher dose, if you give higher doses, there are chances of patient going in phase 2 block. Phase 2 block is similar to the non-depolarizing sort of block. Okay. So the reason for sensitivity is reduced number, because the effect they are achieving is through competition. Okay. Here, suxamethonium, there is resistance because its activity is dependent on the presence of the receptors. Because there are no receptors, less number of receptors, so we are not able to achieve the relaxation through that way. Okay, because they need receptor for its effect. So their effect will be unpredictable. If you are giving a higher dose, there can be phase 2 block. Phase 2 block is like prolonged effect on the neuromuscular blockers, neuromuscular junctions. And you understand? Everybody understood? Okay. So if the patient is presented for Rabia, the question is to you now. How will you manage a patient going for thymectomy? Rabia, would you like to say something? Patient with myasthenia gravis presented for thymectomy.
Okay, sir.
What will be your concern in addition to what we have discussed?
So I haven't listened the previous discussion.
Okay,
but
just try to sum up. I will.
Sir.
Yes.
Sir, the patient coming for thymectomy, I would look for the duration of disease and severity of disease. My concern would be to see the duration and severity of disease and optimization before surgery, and also any comorbid or any pulmonary function derangement in the patient that should be optimized before the surgery. And also I would optimize patient. I would take the consent for mechanical ventilation and destination of the patient post-operatively, and these would be my concerns.
Okay.
And also,
what will be the concerns related to presence of something in the thoracic cavity? There would be something related to that thing?
yes, sir. I would. That would be. I would. That can lead to compression of the structures in the thoracic cavity, leading to Spielberg cava syndrome. So I would do pulmonary function test for that and look for any obstruction or any compression of Spielberg cava, trachea, or and other structures. So will involve the
the approach can be through like proper thoracotomy approach, or they can be approaching through the new technique, this video assisted. Okay.
Yes.
So it can be like you will have a discussion about what's their plan. Maybe they are doing it open, or they are doing it, but you will have to be, because that can be a big one, and there can be obstruction to the airway. Okay. There can be like distortion to the airway, which you are be using. Like there can be presence of superior vena cava syndrome with in this condition. Okay, so you have to rule out in the clinical examination, history examination, and the investigation with special emphasis to the area of interest of your neck. Okay, so you will be seeing whether there is trachea is deviated, CT scan to see the compression, and clinically you can do some Pemberton sign. Okay. So if there is, and you have to induce this patient in a way that you are not leading to airway obstruction. Okay, so this will be a very important concern. If they are doing a thoracotomy, and they can ask you about double Newman tube. So you don't have to tell that, because whenever they are asking you in long case or in table viva, so try to just give them a feel and let them decide where they want you, where they want to drag you. Okay, wherever they want to drag you, they will take you there. So as you told, for the thymectomy patient will have myasthenia gravis. So you have to look into the severity of the disease, control of the disease, any optimization which you can achieve, any coexisting disease, concerns related to steroids, concern related to the autoimmune disease or immunosuppressant medications. And then you will discuss in a multidisciplinary approach. After getting whatever optimization you can achieve, then you will be discussing with the surgeon what is their plan, what is their approach, and accordingly you will chalk out your further plan. But whatever you want to do, you have to make sure that you are telling about the airway management and the altered response to the neuromuscular blockers and the effects of immunosuppressants and the replacement of steroids. These are the main care, and post-operative, as you told, post-operative ICU on the basis of the predictors we will have for the severity of the myasthenia gravis. Okay,
Yes,
so this is all what you will be needing. They can ask you something about the severity according to the ocular involvement, and they can ask you some words about Eaton-Lambert myasthenic syndrome. So what is difference between Eaton-Lambert myasthenic syndrome and myasthenia gravis?
Sir, in Eaton-Lambert syndrome, there is destruction of presynaptic acetylcholine receptors, which are calcium ligated channels by the autoimmune antibodies. And other difference is that in this disease, it improves with activity, but in myasthenia gravis, that does not improve with activity. It worsens with activity. And for myasthenia gravis, we use anticholinesterases. We use steroids and also sorry, sir. And for Lambert-Eaton, we use only the immunosuppressants and plasma exchange. And other difference.
What will be the effect of plasma exchange? I don't think so that in Eaton-Lambert there is role of plasma exchange, because plasma exchange is for the antibodies. Am I right? I'm not sure. Please just check it out. I'm not sure.
Okay.
Because the plasmapheresis is for the antibodies. Whenever you are doing plasmapheresis, it's for actually removal of the antibodies present in the plasma. That's what a basic concept I have. I'm not sure about purely about Eaton-Lambert myasthenic syndrome. The difference which you have to tell that it is sensitive to both neuromuscular blockers, because there is no release of acetylcholine. Okay.
Yes.
So this is the main difference which you have in it. And another thing is that they can ask you a question related to pregnancy. So what you will be doing if the patient is having the obstetric patient, what will be your consideration?
Again, in obstetric patient, my concerns would be a concern of pregnant women, concern monitoring of fetus, and again duration, severity, and control of the disease, and also the intake of the steroids and their replacement. I would involve. There would be a multidisciplinary team, and I will discuss the plan with the surgeon, with gynecologist, and also explanation of post-op mechanical ventilation according to the scenario.
Would you opt GA or spinal, or like GA versus regional? Because when they will be asking you, they would like to listen from you. Whether would you like to give general anesthesia, or would you like to give a regional anesthesia? Plus, will there be any effect in the baby? This is what they want to listen to from you.
My decision would be according to the type of the surgery, and type of the surgery, and also I don't know what surgery are you talking about.
No, talking about cesarean section.
Okay, sir.
Talking about cesarean section in a patient with myasthenia gravis.
Okay, sir. Again, that would be decided on the condition of the patient. If patient is in the severe disease and her bulbar functions are involved, then I would go for general anesthesia. But if patient the disease is optimized, then I would go for regional anesthesia. And the benefits of regional anesthesia are that awake mother, avoidance of polypharmacy, and and avoidance of manipulation of airway and cardiorespiratory depression by the anesthetic drugs, and also fetal depression by the by drugs, and post-op pain management, and
Actually, the pregnant patients are at risk for aspiration. Am I right? Okay.
yes.
And if there is some problem in the like this patient is having at risk, so which is more safe, general anesthesia or regional anesthesia?
Sir, in that way, again, my concern would be according as patient and pregnant patients are having aspiration risk, they have difficult intubation risk as well. So a patient involving bulbar and function, that then I would go for general anesthesia. But if patient is optimized and is the disease is controlled, then I would opt
So
regional.
actually, I would suggest you can say that risk versus benefit, but because
Okay.
general anesthesia will have more control on airway, it is like it's my suggestion just to say that you can give regional anesthesia. But if they
Okay.
ask you, I think I would suggest you to give general anesthesia because you can defend it more securely as compared to regional anesthesia. Though you can say that it's not contraindicated, and if the patient's condition is good, you can go for, because there is some involvement of the immunosuppressants with the cell lines. Am I right? So if the patient
Yes,
is
sir.
having any involvement of coagulation, this is one reason. Number two, you can say that even though the patient will have you will not be in, but sometimes there can be involvement, or like spinal can go a little higher. And if the patient is having whatsoever respiratory insufficiency, that will be pronounced. Okay. So
Okay,
this
sir.
is a suggestion because there is no contraindication. Okay. There
Okay,
is
sir.
nothing contraindicated to give any regional anesthesia in myasthenia gravis. You just have to say that you have to document whatever condition is with any. This is for any neuromuscular issue that you can give. But what is easier to defend? I think general anesthesia is easier to defend rather than regional anesthesia. Am I right? So that's
Yes,
my point of view. So
Yes, sir.
I think any other concern related to myasthenia gravis. So we'll move on to the next topic.
Other concern in this patient would be the position left lateral tilt would be there, fetal monitoring, pre-oxygenation, and also avoidance of the preterm labor. Okay, I'm talking. I was thinking about the non-obstructive surgery in a myasthenic patient. If it,
So that's why a suggestion to anyone who is going for oral exam, I would suggest to write it down, because in the exam you can easily dodge yourself. So make it a habit. Whatever data they are providing you, write it down in a paper. Okay. So that will avoid this problem which you just faced. Okay.
so one thing I want to say, what about the reversal? If we have given GA, general anesthesia, then how would we give an reversal to the patient?
Actually, there are two options. Because now we have Sugammadex. So if you are giving 1/10 dose of rocuronium, please mute the mic. I request all of you to mute the mic. There is a lot of noise coming. Okay, so I think there is one option that if you give Sugammadex, you can reverse easily without involvement of these things. Am I right? So this
For
is
that we have to give rocuronium.
Rocuronium. Yes, rocuronium, you can reverse it. If you give 1/10 dose, because these are very sensitive. So if you give 1/10 dose, you can do it. But in the our exam system, this answer may be questioned to you. Okay. So you should use cisatracurium in a very low dose, and at the end you will check with the neuromuscular blocker, neuromuscular stimulator, what's the situation. If it is needed, you can give, because even the oral dose you can convert it in the IV, and this will not be decided by you only. This will be decided by the physician as well. Okay.
Okay.
According to the situation which you have, because this is a tricky question actually. Okay.
Yes.
There is no problem in giving the reversal, by the way. Okay.
Sir, if we can avoid it, that if given the cis atricurium in low dose, then
Yes.
we would allow the patient to reverse fully, and then by not giving reversal, but
there are
only
there are so many ways by which you can handle this answer actually. Okay.
Okay.
Because sometimes these patient does not need muscle, because they will achieve adequate muscle relaxation even with this one inhalational agent. Okay.
Okay.
So majority of time you don't need muscle relaxation, but
We
it
can
will be
avoid.
variable. You can avoid even if you have given a single intubating dose of any agent. Like there is a question. This is it's a situation in which you can say anything and just have to defend.
Can I say some words I read in a book, that we titrate the dose of the prednisolone which the patient is taken, the dose he or she is taken, then we will convert it into the neostigmine. 30 milligram of the prednisolone.
No, not prednisolone. Pyridostigmine.
Pyridostigmine. 30
Yes.
milligram of pyridostigmine is equivalent to 1 ml of neostigmine. So we will give in titrated doses the neostigmine, and monitor neuromuscular blockade, by the neuromuscular stimulator. Then when the patient is fully reversed, and then we can extubate the patient. Is that a right answer? Or
actually, I told you that there are a number of ways to answer this question. Okay.
Okay.
You can choose any of, you can tell them the options, because if you are telling inhalational induction, this is not a very safe technique, because there can be bulbar weakness and risk of aspiration. So how will you intubate? Would you like to give saxamethonium? Saxamethonium itself has problems. Maybe you are needing more dose, and now then you will be in trouble. Okay. So it's a question. It's up to you, whatever you want to answer. There is no
that's why I was avoiding general anesthesia.
No, you are absolutely right. But in general, they can catch you even in regional anesthesia. That's actually a dilemma, because no technique is safe. You are absolutely right. But you have to tell that if you have to give regional anesthesia, you have to be careful about these things. It's up to you. You have to decide. You can tell that if I'm giving general anesthesia or regional anesthesia, the choice will be individualized according to the patient and according to the scenario I have. Okay. Because there is no pure safe 100% safe technique.
So
yes,
keywords in this question, doctor, that we will say it will be risk against benefit.
Risk versus benefit.
For
versus
VA, I
benefit.
will have better control in the airway, but it has its other problems. And for regional, I am avoid the ventilation problem like this. So it will be risk against benefit.
Risk
don't
versus
prefer.
benefit. Yes. This is answer.
So I should not prefer one against the other.
Exactly.
I say
and
like
you can say that my approach will be individualized according to the individual patient. I cannot tell in every patient that in every patient GA is safe, or in every patient regional is safe, because there are concerns. If I'm doing whatever technique I'm choosing, I have to be anticipating the problems which will be there in that technique. Okay.
Okay.
Yes.
And one point we missed, that other. Yes, Dr. Sabir.
The other one, what we could prefer, because Saxonil, we know that it is a bad drug with bad reputation. We should use high dose of rocuronium, or what is the only
not high dose
of Saxonil?
Not high dose. Actually, if this question is being asked to you in your exam, okay, you will only say it is better to use rocuronium with the Sugammadex. Okay. And the requirement of rocuronium will be 1/10, because these patients are very sensitive to non-depolarizing muscle relaxant. So in Saudi Arabia exam, it's very easy to manage. Actually, the other people who are listening, they are appearing in the Pakistan exam, where there is not much availability of Sugammadex. I don't think so it's available in Pakistan, Sugammadex. Okay. So
because this patient is suspicious to have difficult airway because this has mediastinal mass, maybe compression to the airway like this. So
Yes.
maybe succinylcholine will have optimal airway condition.
Dexamethasone, not necessarily, because you have to give a higher dose.
Yes.
And another thing is that another thing, catching point, please. If you have a patient with difficult airway, never say muscle relaxant. Awake fiber optic. Why are you not saying awake fiber optic? You will say in this scenario, where there is any problem related to difficult airway, you will not say any muscle relaxant. You will have awake fiber optic. This is one option, or inhalational induction with preservation of spontaneous ventilation. Okay, then do the check laryngoscopy. If you are able to see the vocal cords, then you can give a small dose of muscle relaxant. Otherwise, you will not give muscle relaxant. Okay.
As if it is emergency situation, CS during emergency situation, just so for rapid sequence induction.
Yes. No, you are right. But no. Actually, remember this thing. If you have any problem related to difficult intubation, never say succinylcholine. Because practically speaking, we do like that. But in the exam, forget for a while. Forget.
Yes.
Put tape on your mouth for succinylcholine. Actually, in your exam, you should not use it for whatever reason, only because you will not be able to defend it. Okay. Because they can catch you that there was problem, anticipated difficult airway, and now you give succinylcholine. Now you are not able to ventilate. What will you do? And there is no guarantee that succinylcholine will not have a prolonged effect. The succinylcholine can have prolonged effect, and nobody can predict it. Am I right? So you can say the use that it's a very tricky situation. There is nothing 100% safe, and you have to outweigh risk versus benefit. Okay, Rabia, are you clear?
Yes, I'm clear.
Okay. So my question is to anyone else. Anyone has any doubt? Anyone wants to add anything to this Myesthenia gravis? Anyone would like to say anything? And like these are some drugs which are increasing the effect of muscle relaxants, and also the same true will be for Myesthenia gravis. Okay, so what have they written for Myesthenia gravis in pregnancy? Yes, for Rabia, we forgot to discuss that this patient can have transient symptoms of Myesthenia gravis. So this baby should be observed and monitored in critical care, because maybe this baby also needs a mechanical ventilation. Okay.
Yes. Weakness for,
you see, like they have written, during labor, epidural analgesia with a low dose mixture of local anesthetic and opioids reduces the requirement of systemic opioids with minimal motor block. Myesthenia may affect the muscles utilizing during the latter stage of labor, leading fatigue and increased need for instrumental delivery. Epidural analgesia may be, so there is no problem. A patient with significant respiratory valve may not tolerate mid-thoracic level of neurexal blockade. Okay, Rabia? That's what I was telling you. And general anesthesia is advisable.
Okay, sir.
Regional anesthesia such as tap block may be of benefit in these cases. Okay, so that's what actually we were discussing, that they can combine the scenarios. Okay, so you don't have to leave your basics. The basics are airway, breathing, circulation. Whatever the case, whatever the scenario comes, you just have to add it. If there is pregnancy with Myesthenia gravis, don't worry. Actually the answer will be very easy. Why? Because there will be you have a lot of margin to speak out. Okay. And you just have to tell the basic points. Whenever there is Myesthenia gravis, you have to rule out any other autoimmune disease. So thyroid problems can be occur, or any autoimmune disease. Okay. So
Sir, I am a bit bad in searching the articles. The articles you are reading from, can you kindly send me?
You will have to transfer at least $1,000 to make you learn. If you are like attached with me for so long time and you are not able to search the articles, there should be some neurological assessment for you, Rabia.
Yes, sir. It is there, sir. Please.
No problem. No problem. Okay. So actually, I would just tell you this thing as well. The people who are new here, they can just see that this is the main link. Okay. And there you will see articles and books. This mind map, which I show you, it's excellent. Please do search these mind maps and it will give you a very quick revision. These are some topics, why questions. So articles, Rabia, and then you will go to articles and tutorials, and then you will see topics. It is in the neuromuscular system. So you will go here, okay? And then you will see neuromuscular, okay? And then you will find it here.
Okay, sir.
Okay?
Thank you, sir.
All the topics are arranged like that. All the topics, if you want to, and there is a shortcut. You can just write it here, whatever you want. Myasthenia gravis, you will reach it, okay?
Okay, sir. Thank you.
So this is the other way. Okay. So can we move to our next topic? What did I write? This was tetanus or GB. I think GB syndrome we will do, because today I have to just leave somewhere. Where is GB syndrome? What is GB syndrome, by the way?
Sir, GB syndrome is acute and inflammatory demyelinating neuropathy that is also autoimmune, and it is preceded mostly by any infection of respiratory or gastrointestinal tract. And it is
preceding like it's motor weakness preceded by some acute viral infection. Okay.
Okay, sir.
So what are the usual, because they will ask you question in the similar way. Okay. You can tell that there are at this point of time, you can tell there are few variants. You can tell at this time, or if you want to tell later on, they can ask you what is the clinical presentation. What will the next question will be? What is the clinical presentation of GB syndrome? Then you can tell about the variants. Okay. You can tell about the variants. So what are the variants name? At least you should be knowing the name of the variants.
Yes, sir.
What's the name?
Different types: acute inflammatory demyelinating polyneuropathy, chronic inflammatory demyelinating polyneuropathy, Miller-Fisher syndrome, and acute motor axonal neuropathy, and acute motor sensory neuropathy.
Actually, they are very pathetic, but you can say the most common you have to tell first. So this is the most common, AIDP, and then Aman and Amsan. Okay.
Yes, sir.
Aman and Amsan and Miller-Fisher. So this is the most common acute inflammatory demyelinating polyradiculoneuropathy. I don't know who created these names, but then whatever the name is, the presentation will be like that. Okay. Well, what will be the usual presentation? Like there will be areflexia or hyporeflexia, muscle weakness.
Asymmetrical flaccid weakness.
Yes.
With areflexia or hyporeflexia.
Okay. So, and this is
autonomic dysfunction.
Acute motor axonal neuropathy. Okay. I don't think so they can ask you about too much details. Just you should have, at least you should be knowing the names. Okay. Because here there will be more, you see, what is the difference between Amsan and Aman? There is sensory involvement as well. Here there will be motor involvement only. Okay.
Yes, sir.
So this is polyradiculoneuropathy. This will also have more predominant motor involvement. Okay. And
yes,
Miller-Fisher has ataxia, areflexia, and ophthalmoplegia. Okay?
Ophthalmoplegia.
This is the question which comes in MCQs about Miller-Fisher. Okay. So now they will ask you what are the organisms which are associated with GB syndrome.
So Campylobacter is the most common organism involved. Others are Sir, cytomegalovirus, Epstein-Barr virus, and and for respiratory tract, it is mycoplasma pneumoniae.
Okay, so they will ask you this question, then they will ask you what will be the clinical sign symptoms. So in addition to motor and sensory weakness, what you have to tell in start, what will be the problems which you will be seeing? Autonomic dysfunction. Okay, and actually we missed in myasthenia gravis as well, because in myasthenia gravis there is also autonomic dysfunction. Okay,
Yes,
so here it will be very pronounced autonomic dysfunction, hypertension, hypotension, tachycardia, bradycardia. Okay, so and asysto and involvement of the same vital capacity and the same risk of aspiration because of this one, because of the involvement of the bulbar system. Okay, so there is not much difference between GB syndrome and myasthenia gravis with regard to evaluation. Yeah, usually there is no confirmatory test. What are the tests which you can do? Clinical history examination. There can be some, you will find muscle weakness, ascending paralysis. This will be the clinical feature. Okay, and then you will not find any other disease, and you will rule out. What else you will rule out, Rabia? Anyone wants to interact? Yes, what else would you like to rule out, Rabia?
Sir, regarding sir, any CNS pathology?
CNS pathology, and
yes, and
in the differential diagnosis, you can say anything, no? You
sir,
can say
any metabolic abnormality, any
metabolic electrolyte,
dysfunction,
electrolyte.
any drugs? Yes, sir. Metabolic electrolyte drugs, vitamin deficiencies, and
you see, you can see metabolic, infective. Okay, you have to differentiate between polio toxins. Okay, lead poisoning can be like that. Okay,
yes, sir.
And maybe if it is presenting in the ICU, it can be critical ill, because usually GB syndrome has a clinical diagnosis. Okay, but exacerbation of any other disease can be presented like that. Okay, so you have to rule out, because there will be autonomic dysfunction here as well. So you have to just differentiate between them. Okay, so the test which you will be doing, which they ask in MCQ, is raised protein. Okay, in LP you will find raised proteins, and in any other neurological problem, you have to do nerve conduction,
electromyography,
and electromyography. Okay, and CT and MRI.
Yes, sir.
And you can have the infection screen. You can find, and this is like
things we would do, the serum electrolyte levels, vitamins levels, TFTs, and these kind of tests.
Yes, you see, there can be some electrolyte imbalance as well, like syndrome of inappropriate ADH. Okay, so this will be the things which you will be, usually this will be a clinical diagnosis rather than any diagnosis with some investigations. These will be supporting, not the diagnostic features. Okay, like in any neurological problem, whatever test you can do, CT, MRI, and nerve conduction studies, and to see the severity, you have to do the pulmonary function tests. Okay, what will be the management?
Sir, in management, again, in management, there would be supportive and specific management. So in supportive, we will give ABC, deal the patient with ABC pros, psychological management, pain management, and all the general ICU care of the patient. And in specific management, there is the treatment of the cause, if the infection cause, and steroids, immunoglobulins, or plasma exchange.
Okay, like main focus will be on if any identifiable cause, you will be treating it. Okay, and usually it will be airway, breathing, circulation approach, the general ICU care. Okay, and care related to autonomic swings. Okay,
Yes, yes.
And usually this question is being asked in ICU scenario. It's very least likely that they can ask you in operation theater setup. Okay, so actually this is an ICU question. So general supportive care you will be giving. Okay, and like they will ask you, Tayyaba, would you like to add something?
So psychological management support
Yes,
should
sir.
also be.
There should be a multidisciplinary approach, as said by Dr. Rabia. That
Okay.
I would like to involve the respiratory therapist, intensivist, and I will also think about the early track and tracheostomy care and
Yes.
speak therapist,
Okay.
and dietitian and nutritionist as well. And I would also like to involve psychologist as a psychotherapist for the patient, because this is a
Just a
long-term
second.
disease.
Just a second. I just want to recall for everyone, there is a like mnemonic for the journal ICU care. Someone can recall this
That is
mnemonic?
fast hugs in bed.
Fast hug. Okay. There are so many. So what will you be doing? Fast hug. What will be that fast hug?
I will be taking care of the feeding of the patient, analgesia, sedation, about thromboprophylaxis. I will be also watching about the thromboprophylaxis of the patient. I will be taking care of the
What is H?
hypothermia. This is
Hypothermia.
the risk of hypothermia. Yes. About the ulcer care, about the ulcer prophylaxis, PPI in the high risk patient, not in all the patients.
Okay.
I will be also taking care about the fast hugs, about the GI care, and
what is left in fast hug?
the sore
Actually?
cares.
Bed sores. You see, very important.
Bed sores
Bed
care.
sores.
Yes.
Physiotherapy. I would
Position
say,
care.
yeah, just I will remind you people that this question can be asked in the ICU part, because they try to find out something new, and there is a topic of physiotherapy, role of physiotherapy in ICU. Okay, so you should be preparing this topic, physiotherapy in ICU. Physiotherapy will have part in this patient, in any other patient. If you are, and they are asking more, so you can tell these things which you have told. Okay, try not to say the mnemonic in front of the examiner. It's not a very nice thing. Okay, this is just for your recall rather than telling them. It does not create a very good impression in front of the examiner that you are telling a mnemonic. Okay, so like you were saying, psychological support and basic, and you say a very simple question: when will you intubate the patient? Like just GB syndrome patient can have different like.
There is a criteria. Yes.
Yes, when will you intubate?
So this also depends upon the clinical condition of the patient. I will want to see the ABGs of the patient and the hypoxia and the respiratory. Is there any respiratory failure? I would like to do the spirometry and do the vital capacity. If it is less than 15 ml per kg or less than 1 liter, I will want to intubate the patient. If the peak inspiratory flow rate is less than -30 or peak expiratory flow rate is less than 40, then I will intubate the patient. If there is any involvement of the bulbar muscles, bulbar weakness, then there is a risk of aspiration. So I would like to intubate the patient. So these are the indications in which I would like to intubate the patient, and also then at autonomic instability as well.
Okay. Okay, so you have to take care of these things: aspiration risk, autonomic problems, and general ICU care. And the things which can improve the symptoms are, what are those? Which will improve the symptoms?
Plasmapheresis and immunoglobulins.
Yes, plasmapheresis and immunoglobulins. Okay, so
Sir, I would like to add some new modalities of treatment which are being used now in GBS. These are the CSF filtration. There is the other drug which are now being
what is
on the
that?
trial
Please,
basis, which
please,
is
please,
the
please, you are very
CSF.
fast.
Sir,
CSF what?
so that is the CSF filtration.
CSF filtration. Okay.
Yes, this is a new modality which is being used by some centers for the GBS. There is also some role of steroids, but not as a monotherapy. You have to combine with the immunoglobulins or the plasmapheresis, and
Okay.
also the complement inhibitors. Eculizumab is also being used for GBS, but not large RCTs are being studies for this drug.
Yes. How to do plasma exchange?
So this is basically done prerequisite of the plasmapheresis is the clotting. I would be like to have a clotting profile of the patient for plasmapheresis, and this is being done in the patients who are unstable, in which IV immunoglobulins are now being used, and this is done as a 3 to 5 treatment cycles are given over 5 to 7 days, but I don't know exactly the procedure of plasmapheresis.
Like you just like you told that you have to get, because this will not be your decision, this will be a decision of multidisciplinary team, okay, and it is passing through just like any extracorporeal, it will be coming an exchange, okay, and as much volume you are removing it, you are replacing it with the FFP or albumin, okay.
Okay.
And they can ask you about IV immunoglobulins, a few words. What are the problems associated with immunoglobulins?
Sir, yes, there are some problems which are being associated with the IVIGs. One is the anaphylactic reactions, and nausea, fluid overload can also happen in a patient. So you would be very cautious to give an IVIG in a patient who are already in the overload or the congestive heart failure patients. And it can also, the patient can also go into acute renal failure and deranged LFT. So these are the things which you will, encounter after IVIGs. So, and this is, if this is done in the first 2 weeks, then it will be giving good results.
Okay,
But this is expensive.
my same question, that which other conditions are being treated with IV immunoglobulins and plasma exchange?
One is the Myesthenia gravis.
Okay.
Other tetanus.
In tetanus, yes. Okay. Actually, any if you want to just recall.
Any poisoning, we do plasma exchange.
For which poisoning, sorry?
Any toxins taken can be treated with plasma exchange or hemofiltration.
Any you can.
No, we are talking about the immunoglobulins.
No, both of them. Both of them,
Okay.
Tayyaba, both of them. Okay. In which patients, which other patients you can use plasma exchange, or because this plasma is just a brain, just chalk it out. Even I cannot recall too much, but usually whenever there are some antibodies, you can wash them out. The simple theory is there. Okay. So anything you want to add regarding these topics?
I want to add one thing, that these patients are usually, as Dr. Taiba has very well explained, one thing is that when we are going to intubate the patient, we would avoid the sucks as it can lead to life-threatening hyperkalemia. Another is that early tracheostomy should be planned, because these patients are for long period of intubation. And third thing is the pain management, because these patients have severe pain. So these 3 things should be care of in the ICU.
Actually, for you people, only for you and Tayyaba, for other people, there can be some MCQs out of it. But usually in this question, whenever they will be asking you myasthenia gravis or GB syndrome in table viva, there are some, because they have to ask you a number of things. Okay. So as much as we have discussed, this is more than enough. And Tayyaba, whenever you are telling something new, see the examiner. Majority of people now know what sort of examiners are there. Okay. So if you find the examiner to be helping and you are going very nicely and you have finished everything, then at last you can see new modalities. Okay. Because they, you see, never challenge an examiner. Because examiner can twist you at any point of time. Okay, so you can mention it, but only when everything is going fine. Okay, at the end you can see. So main selling point for GB syndrome is that it has a clinical diagnosis, it has different variants, it has no specific management, it has all generalized management, supportive care, general ICU care. Okay. So this is all about GB syndrome. Actually, I just have to go out somewhere today. So I will be finishing the discussion here. We will continue the neuromuscular system from here tomorrow. Okay. So tetanus, tetanus, muscular dystrophies, and ischioid weakness. We will try to cover all three. Okay. So thanks all of you for the participation. Thanks our international audience. So I will be very happy to get any feedback from you. Okay. And any questions before we finish? Okay, Tayyaba and Rabia, special thanks to you.
Okay.
And all others also.
Thank you, sir. Assalamu alaikum.
Walaikum assalam.